Hello, and welcome to cuppa and a case study, Unilateral Lymphedema and Early Detection Case Review. My name is Joanne Yao, and I am the Senior Director of Marketing for ImpediMed. This is a fun, informal 30-minute case study review with two very experienced panelists. Louise Koelmeyer, PhD, occupational therapist and lymphedema therapist, Director and Senior Lecturer of the Australian Lymphoedema Education Research and Treatment Program at Macquarie University, and Adam Brown, Key Accounts Executive with ImpediMed. Feel free to send us questions at any time during this webinar using the Q&A icon on your screen. We will answer as many questions as possible and will follow up on any questions that we are not able to address live. We're also happy to offer certificates of completion upon request. To request a certificate, you may either respond to your registration confirmation email us at info@impedimed.com, or contact your local SOZO representative. Now I will turn it over to Louise and Adam.
Thanks, Joanne. Louise, how are you? Good to see you.
Hello, Adam. Nice to see you. So far away these days. I miss you.
Oh, thank you. Same. I was just thinking it's nearly 6 years since I met you the first time at the ALA conference in Darwin. So who knew that 5 or so years ago we'd be on a Zoom call. I'd be in Dallas, Texas, and you'd be in Sydney, locked down, unfortunately, in this current climate. So things have changed very quickly over the last few years, but absolutely wonderful to have you on the call today. So appreciate your time as always. How's life down there?
Thanks for inviting me, Adam. It's really good to be here. And hello to everyone who's got up early for this cuppa and a case study. Hope you've got your cuppa with you, and hopefully we can have some really good discussion. I think those who may know me well know this is a real area of passion for me, working both in breast cancer and using this technology. So look forward to it, Adam.
Awesome. Okay, let me just share my screen. So as I said, we were just highlighting one of your particular patients, which I think I've had the opportunity to meet firsthand. And I know you have lots of information on this particular patient. So before we kind of get into things, just want to give a bit of a background of this patient that we're using for the case study today. That'd be awesome.
Sure, Adam. So this is my patient, Marilyn. She's allowed me to talk about her history. And as you can see here, I've actually known her for 10 years. So she's a long-term patient of mine, and she was very much has come in to this prospective surveillance model of care with me. And over this 10 years of my clinical practice working with her, I guess my knowledge and experience has developed and increased. The technology has increased, and it's fantastic that I can actually, as devices have changed, I've been able to carry home measurements over into the SOZO hub as we've got here today. So Marilyn was 65 when I met her. She is married, has a very supportive husband who comes to almost every appointment with her. You can see, I think I've taken 40 measurements or over 40 measurements in that time. And I guess for me, Marilyn would be your typical woman who's diagnosed with breast cancer, and I always do risk stratification to start with. So when Marilyn presented to me, she was going to be put in my high risk stratification group because she was having a mastectomy, a right mastectomy, planned to have an axillary lymph node dissection. She's going to be having taxane chemotherapy and also radiotherapy. So for me, they're the red flags to say, this lady is going to need lots of education, lots of partnering with me and monitoring so that we can manage her in the best way possible.
Yeah, fantastic. And we'll certainly have a look at the case study in a moment. What I actually did realize when we were discussing yesterday, and when we look at the screen that you can see, there's a lot of tags that you've actually created. So this is one of the new features with SOZO version 4. So I just wanted to take a couple of minutes, perhaps, if I dive into your administration area, if you allow me to do that, we can have a look at kind of what you've set up, because it's quite interesting the way you've gone about that. And then we can get into the actual case study itself. So if I click over into your admin section and we go into tags, we can actually have a look at what has been developed from your side. So do you want to talk us through kind of what your thinking was with tags, you know, how you're using the tags? And I know it's beautifully color coordinated, Louise. So
I know,
let's have a look at that as well. You've done well.
And I think Thanks, Adam. And I think we said that if people were sitting in front of their own SOZO hub, they could even work through some of this with us if they wanted to. So I've been exploring the tag function since it got introduced in one of the latest software editions, and I am having fun with it. I like the colours. I'd probably like a few more colours. Adam, if you could add some more colours to the repertoire here. But what I've tried to do is group my tags according to common themes, I guess. And so the purple tags there, I started off with a pre-op baseline because Marilyn, that we'll see in the case line, had a pre-operative measurement, which is, I guess, our ideal best practice. We want to try to engage individuals at the time of their breast cancer diagnosis. So I've got a purple one there for pre-op, and then she had some post-op swelling that we'll see. So I sort of grouped those together. Then I put the breast cancer treatment-related features. I gave them a colour, so chemotherapy, radiotherapy. I put a separate tag for taxane-based radiation. So they're one colour. Then I've got in the orange sections, I've got sort of some highlighted things of, you know, be aware, infection or cellulitis or any trauma-related things that are potentially going to exacerbate somebody's symptoms or things I need to be aware of. I've got there the red section, which is some of the interventions that might occur for individuals. So whether someone needs intensive complex lymphedema therapy, I've got that as a bit of a red. Because I work in a surgical program at Macquarie University, I've got the surgeries that we often offer to patients. So liposuction, lymph node transfer, lymphovenous anastomoses. I've got there a non-related medical. So if a patient comes and they've got some changes or something else going on that I need to record, I'll put a tag there. And then I've also put a tag for stages of lymphedema and compression therapy and different options of compression therapy, just to give me some information. And I've been playing around with it for a while.
Yeah, no, I mean, it's been a question that I've been asked a little bit. How do we use tags, you know, from a therapist perspective? And I think that the discussion almost was, do we need to set some specific tags, you know, as part of our software, or is that something that's very much individual? What's your thoughts on that, Louise?
Well, I've developed these sort of generally from my own clinical experience and predominantly working in a breast cancer lymphedema population, both in the prospective surveillance model and clinical lymphedema. There's certainly some of these ones here could be very broad across the broad range of all lymphodemas. So it could be an option to have some set ones.
Yeah, awesome.
I'll sell you these ones if you like, Adam.
Sure. Yeah, make me an offer. So let me jump back into the patient we're going to have a look at. So I appreciate that. I thought it was just an opportune time just to see what you're using from a tag perspective with some of these new features. So let's get back into this particular patient. So if I go to, you know, the very first measurement, I mean, they'll all come up as part of our history. But just talk me through, I said earlier on, you know, there's ways to use our technology. So there's early detection of lymphedema, you know, number one. That's a great way to use L-Dex, and we want to investigate that a little bit. And then also, if someone does have clinical lymphedema, you know, how you're utilizing L-Dex is really useful as well, I think, for the people that are listening today, and certainly from our side as well. So I guess, do you want to talk through, I guess, your understanding of L-Dex, how you've used it in that early detection, you know, model of care phase that you talk about? It'd be great to expand on that for us.
Sure. I think I'm very passionate about this model of care, and I see it as a model of care. It's not just taking an L-Dex reading, it's a complete model, and education is the key here. I think education and empowerment to your patient is integral to any therapeutic relationship. And so whether you're seeing an individual as a private lymphedema therapist, or whether you're seeing patients as part of a multidisciplinary breast cancer team, whoever is taking these measurements, it's part of the model of care. So the equipment, yes, it's important to have the equipment to do the monitoring, but it's not the be all and end all. It's the model of care that we're looking at. So the model is, let's get these individuals in early, ideally at diagnosis of the cancer, and then monitor them at regular intervals. And so when you look here at this L-Dex chart, there's quite a few measurements there, but for me, it's over time, it tells a story. So it's not just looking at one individual measurement. Yes, when you take a measurement, that's interesting or good, but it's telling a story over time. And so, you know, educating your patient from day one about what we're trying to do here, why we're engaging that individual in being monitored, and getting them to feel like they're part of the partnership in wanting to help themselves to prevent lymphedema.
Yeah, fantastic.
Can you talk about that a little bit more, Louise? I mean, when you're at the very beginning, introducing a patient to this for the very first time, how do you describe the model of care? How do you describe L-Dex, and how do you describe SOZO?
Sure, Joanne. Well, it's often very individualised in that I'm fortunate to be doing it in a private practice setting, and so I'm a one-on-one therapist to patient in in the environment of the clinic, and so it's very individual because at that time someone's newly diagnosed with cancer, which is a highly stressful and emotional time, and sometimes all I need to say is, gee, you've got a lot going on at the moment, and then the tears flow. I don't know it's my room or my face, but I seem to go through the tissues frequently because it's very emotional. And often I say when I'm teaching students that our patients can be very brave and they stand up or sit down with their surgeon or their oncologist and they listen to the information and they listen intensely. They've often got their partner with them. And they get the information of what they've got to do next for treating the breast cancer. But when they come to me, I guess they've got some time, they're a little bit more relaxed, and I engage with them that just listening to them to develop that therapeutic relationship, because I'm going to be with them for this long journey going through all of their intensive treatment. So in that first couple of appointments, I might not be talking a lot about lymphedema. So I'm talking just some generally about coping with what they're going through at the time. But I'm listening to them, I'm engaging with them, and I just give, and I call it the drip filtering of education. So I mentioned the word that there's a potential risk, and in this case that we're talking about today, I knew she was going to be high risk because of the planned treatment. So she was referred to me because of being high risk. So I want to give a little bit of information, but I want to build on that information over time. So I talk about what lymphedema is in very basic terms, but I repeat that information and build on it each time I see them. When I talk about L-Dex to the patient, I give them the little brochure that gives some information. I write down their L-Dex score, and it's interesting, these people bring their L-Dex score every single time they come to see me. And, if they forget to bring it, they get worried, not realising I have the data, I have all the measurements in my file and on the hub. But it's something that really they feel engaged with and feel empowered that they can have control. And so if you explain what the normal range is and what we're looking for change over time, if you get them engaged, you've got them on board, and then you work with them and educate them along the way.
Thank you, Louise.
Awesome. So if we look here, Louise, in terms of this particular patient for our case study, so we've got minus 2.7. That's obviously been set as the baseline. So that was the first point I saw her. That was a pre-surgical baseline. So just before she was going to surgery, so I was able to set that as her baseline. Sometimes I may not always get that pre-surgery baseline measure. So I will monitor and, set the baseline if I feel after surgery. You'll see here for this case that there was a little peak after surgery at that 3.9 measure. And that's where she had some post-surgical swelling. So that's not lymphedema, that's normal, a bit of build-up of extracellular fluid after surgery. Yeah, and I think just going back to that point on tags, I think if we bring that up, you've just put that in there for your perspective. So we've got post-op swelling, we know what that little spike in the L-Dex score was. So it gives you as a therapist a little bit of guideline, to figure out what's happening there. So that's the first little spike, and then obviously post-op swelling dies down, Louise, and then it kind of seems pretty stable.
Yeah, that's right. And then she started her chemotherapy. So she had a combination of taxane chemotherapy and AC, and we all tend to know from the literature that having taxane chemotherapy can retain fluid. Generally, it's whole body retention of fluid, but if someone's got an already compromised lymphatic system from surgery, then potentially it's going to be harder for the fluid to drain from that at-risk limb, which is what we see here in this case. And I see in many patients that they actually increase their L-Dex reading. But in my education to them, I'm actually telling them I'm not going to be alarmed if it goes up. we expect this. I might intervene, and I did in this case. As it started going up, this patient was really motivated to do everything she could to try to prevent lymphedema. So we actually prescribed her with a compression sleeve. At about that point there, or the next one, I think, Adam, we prescribed a compression sleeve, ready to wear class 2, 20 to 30 millimeter compression sleeve. And I wanted her to ideally wear that about 10 to 12 hours a day during that period.
So was that at the L-Dex group 8.8?
8.8, yeah.
Yeah.
So she wore that, but as you'll see there, she was only in the early stages of taxane, and she continued to increase her L-Dex reading even while she was wearing that sleeve, until it got to a point, and then the sleeve really helped also. And as the effects of taxane left her body, we had a significant reduction after that. So at that point there, she's still wearing her compression sleeve, and she was very diligent in wanting to be engaged and do whatever I recommended.
And is
Hey,
that
Adam,
go for it, Joanne.
Do you mind scrolling down a little bit so that the audience can see the dates at the bottom of the graph?
There we go.
Thank you.
Thanks, Joanne. That helps me too.
No problem. So, and that's a sort of a common occurrence in terms of a patient that's high risk with taxane. You'll generally see that increase in L-Dex, or is this, you know, particular to this patient?
No, I often see it increase with L-Dex, and you only have to look at the patient, and they've often got swelling in their hands and feet, you know, all over. They may feel even their abdomen's a bit distended. But what I explain to my patients is why the L-Dex is going up is that the fluid, the extracellular fluid, is moving into that at-risk limb, but because of the compromised lymphatic system from not having those lymph nodes removed, it's taking longer and it's a bit harder to get it out. Get that fluid out, pump the fluid out. And that's where getting someone to be diligent with exercises, wearing the sleeve actually helps to add a bit of extra pumping to move that fluid out during that taxane time.
Yeah, fantastic. Yeah, and just a side question from my side. I mean, this is, you know, we're talking February, you know, March, April 2012. It's now 2021. Is there, in terms of your treatment of particular patients from, you know, this is quite a few years ago to now, has there been any advancements from your side? You know, I know you just mentioned exercise there a little bit. Like what has changed in terms of the landscape on treatment for a patient?
I think probably for me, over 10 years ago, I was playing around with this, and I was aware of the literature and the research in this space, in the, you know, prospective surveillance model of care. I guess me working in this space now, I'm more, I guess my understanding of the technology and of the model of care has increased. And so I'm more committed, I guess, to implementing early intervention, as long as I have that support of the patient, that individual in front of me. There's some patients who say, I can't wear this sleeve while I'm going through this chemotherapy because chemotherapy is just knocking me around so much, I can't bear to put a sleeve on. And I totally have to respect that for someone. But often at that stage, people, you know, they're a little bit overwhelmed with everything. And if you can explain to them that this is trying to help prevent a longer term problem in the future, then often they're okay about wearing them. So it's got to be that communication and that relationship that gets that patient on board.
Yeah, fantastic. So then before we have a look at some of the additional data we have on this particular patient, if someone's trying to implement an early detection model of care program, if you had to say, you know, 3 points, 1, 2, 3, what's some things that you would recommend for people that are on the webinar today?
Okay, the first one would be education. It's key to anything you do. Education to both patients, but education to a multidisciplinary team. Now, whether you're in private practice or in a large cancer centre or hospital, you need to engage members of the multidisciplinary team. So you speak to your surgeons, you speak to your oncologists, you speak to your breast care nurses, you get people engaged that this is the model of care the whole team wants to engage in. Because it's not always just about L-Dex, and we know in the cancer population and the features and advances of the SOZO technology, we can look at the body composition, we can look at the segmental measurements, and all of that adds value to supporting an individual while they're going through a cancer you know, treatment and rehabilitation, survivorship after cancer. So education is key. You're wanting to have the resources and the clinical pathways and protocols in place of how these patients are going to tap into this service. How are you going to get your referrals? How are you going to be able to set up a protocol that, you know, you may have to risk stratify. You may not have the resources to be able to monitor every single patient in the same manner. So risk stratification is really important. And I think important to have that as a team discussion because, you know, you want to get those referrals. You want the right people coming to have access to this model of care. And then I guess you've got to have, when you've got your pathway in place, you need to know what to do when someone triggers the need for early intervention. So it's the whole model, not just, you know, one of those components.
Yep. Yeah, fantastic.
Louise, you mind if I interject with a couple of audience questions?
Sure. Hope they're not too hard, Joanne.
This one's hard, so I'm going to put this one with Adam. Or Adam, you can punt it back to me. But
I may do.
The question has to do with if a therapist doesn't have access to SOZO themselves, but wants to refer a client to someone who does, how can they find out who in their local community has SOZO?
Yeah, I mean, obviously on our website at the moment, you know, depending on what country you're in, you can certainly get a resource there. I think even some of our, I guess what we would class our key opinion leaders have a very, very good understanding of who has the technology. You know, Australia in terms of SOZO usage at the moment is pretty extensive. So through the public system, through Queensland Health, New South Wales Health, you know, a lot of the in Victoria as well, Western Australia, everything's covered a lot. So if you want to give our ImpediMed office in Australia a call, reach out to our customer support team. Many on the call would know Irene. She's more than happy to provide some opportunities for that. But, you know, certainly there is really wide coverage now, you know, across Australia and New Zealand. You know, if someone's on here from the US, you do have access to our, you know, locator as well in terms of our SOZO service on our website. And just if you haven't been on our website for the last little while, there's been some fantastic updates, you know, in the resource and support section. So reach out and have a look at that. All of the previous webinars are on there. There's some YouTube links on there and a lot of extra information around SOZO, you know, that's been added from our team the last kind of 3 to 4 months. So make sure you check that out. So that'd be great. Thanks, Joanne.
And I could add there that if somebody doesn't have access to the SOZO device, that doesn't mean you can't implore this model of care. So, you know, the BIS technology is really the gold standard in this early detection of subclinical lymphedema. But if you haven't got access to the technology, but you're seeing, you know, a few patients every now and again who are going through breast cancer treatment, then start with the tape measure and use circumferential measurements to monitor. You know, there's plenty of little calculators that you can find out on the internet to put in the measurements, use the ALA guidelines for measuring with the tape measure, and at least get some baseline and monitor that way to give you some information. The tape measure is harder to detect subclinical lymphedema because we're looking at a very small volume change, really no volume change. So I know in the big PREVENT study, we were looking at greater than 5 and less than 10% change, which is hard to monitor with the tape measure, but it's still better than nothing.
Yeah, good point.
Thank
Did you have another question, Joanne, before we go for it?
A couple other questions for you. How long after a patient finishes taxane chemotherapy, how long do you expect it takes for their L-Dex score to decrease?
It does vary, Joanne. I say to my patients in my education that it can take 3 to 6 months for some of the effects of taxane chemotherapy to move on. I often relate it with the peripheral neuropathy symptoms that individuals get that can be really quite debilitating. And so, you know, it can take that period of time. But again, exercise is really key to help pumping the fluid out and keeping active. So, you know, the COSA guidelines for exercise during cancer treatment are really important. And you know, if someone freaks at the word exercise, maybe it's just movement. And if someone's meeting a friend for a coffee for a bit of support while they're going through this treatment, maybe say, can we walk for 15 minutes before we go and have the coffee? Just trying to move is going to help both the fluid in their hands and their feet and their at-risk side as well.
Thank you, Louise. And final question that we have right now is, you talked about risk stratification as part of your pathway. Would you talk a little bit about how you risk stratify your breast cancer patients?
Yeah, so really I try to look at the literature from identifying high and low risk, but I very much believe that you can't be educating someone the same way across the board of all breast cancer diagnoses, because a woman who's diagnosed with an early stage 1 breast cancer, who has a lumpectomy or a wide local excision and some radiotherapy to the breast, and that's all, in the same category as of an individual who's diagnosed with a stage 2 or stage 3 aggressive cancer requiring a mastectomy and axillary lymph node dissection and chemotherapy, taxane and radiation to, to the various different regions, radiation to the nodes. So they're probably my key things. It's treatment related. We do read in all the literature about BMI, but I think I've sort of moved from BMI to more body composition information when I'm talking to my patients. But certainly BMI is one of the risk factors in the literature, and it's a high BMI at the time of breast cancer diagnosis, so over 30. But really it's lymph node treatment is your key priority area for identifying to high and low risk.
Mm-hmm.
Thank you, Louise.
Fantastic. So we have just about 5 minutes left, Louise. I just wanted to kind of, we've kind of talked a little bit about the early detection side, what happened here in, the taxol. There's obviously a lot of peaks and troughs. Do you want to kind of give us a little bit of a history of this patient, but also how you're using L-Dex, in someone who has clinical lymphedema? What's the use of L-Dex and that number, and what it's doing for you, what it's doing for the patient? Do you want to just spend the last few minutes just explaining that for us? I think that'd be great.
Yeah, so as you can see with this long-term history of information, that this lady does have clinical lymphedema. She has very well controlled, and I would say it's a 1 to 2 centimetre difference in the circumference at her various points in her arm now, 10 years after her breast cancer treatment, so taking into account of dominance. So it is very well controlled. But it's why I sort of use this case is that each of those peak points, those 4 or 5 peak points after the taxane treatment, I've got a tag on those because she's had some of the things that, whether they're fact or fiction, have had some things go on in her life that have probably contributed to her continuing to go on this trajectory of getting clinical lymphedema. Mm-hmm. So with Marilyn, she went on an aircraft flight but came home with an episode of shingles. So she ended up with an infection that we know the effects of infection and cellulitis on lymphedema. She was moving house and so lifted some heavy boxes. So the reading of 18.2 there, the next one, I think. Yep, that one there. Yep. So at that time, she moved heavy boxes, and then afterwards, her arm swelled up. So at that point, I put her into a flat knit sleeve. Actually, at that point there was a significant volume difference. So she got some significant changes in the arm size at that point. I offered her intensive treatment, but at that point in time, she wasn't prepared to go down and do intensive bandaging. So I put her up the ante of the stiffness of the compression sleeve. And then that next peak, that one there, the 24.3, I've got a tag on there that she actually broke her leg. So she was in a moon boot for 8 weeks, so not mobile, and she retained some extra fluid in her arm. And then the next peak, over to the right there, Adam, at 25.2, she developed cellulitis. So she's had a couple of episodes of cellulitis throughout her story that, again, is putting her in this category, that each of those things, it's just interesting that those peaks actually are quite normal things that we know can potentially exacerbate or irritate the lymphatic system. So it was interesting after that bout of cellulitis that she then agreed to trialing some compression bandaging. We did some bandaging, got a significant reduction both in the volume and the L-Dex. We got her in a good fitting, flat knit, custom made compression sleeve. And so that was back in sort of 2014, 15, early 15. And she's actually been, I would say, relatively stable for that whole 6 years since. There's, a couple of ups and downs, but her measurements are stable. She gets replacement garments, 2 sets of custom-made flat knit sleeves every 6 months. I've recently changed her, that last peak just before the end of the graph there, Adam. She's struggling with osteoarthritis. And so I did change her into a soft fabric, still a class 2 sleeve, which seems to be still helping her. She had at that point also been a little bit weaning off the sleeve. You know, she certainly doesn't wear the sleeve these days, 7 days a week, 24 hours a day, anything like that. She's very much in control. She still comes to me every 6 months for the sleeves and to be reviewed. She's very much on board. And if you asked her about this model, like you asked me, Joanne, she would very much say that she's felt supported, educated, and in control of her condition. And when you feel her arm, feel the tissues, she's very much a success story, even though she's got some clinical lymphedema. You know, potentially with all of those different peaks that happen in her graph, she could have got a lot worse.
Thank you, Louise.
Yeah, fantastic. So I think we've kind of quickly gone through our half hour. I think we've had a lot of information come through, and I've certainly learned a lot from my side. It's been great to enjoy as you say, Louise, a cuppa and a case study with you today. I had to keep my tea bag in there because that's not whiskey; it's actually a tea, as you know. So lovely to see you. Thank you for your time, Joanne. Did you have any last words for Louise or anyone that's listening today?
Hey, thank you, Louise. Can't thank you enough for your participation. This has been really helpful. We're getting great comments. There's a couple questions we didn't get to, but we will have the team follow up with you separately. Make sure you get your questions answered. And as always, you can find replays about 1 week following this event at ImpediMed's Oncology YouTube channel. So look out there for replays. They get posted regularly. Thanks so much, Louise, and thank you, Adam.
Great. Thanks,
Pleasure.
everyone. Have a good day.
Thanks, guys. Take care.
Bye.